Okay, hello everyone, and thanks for joining us today. My name is Jasmine Afawi, and I'm the Managing Director here at the Save Your Skin Foundation. I welcome you to today's webinar, which will review breaking news, key takeaways, clinical data, and other updates presented at the Canadian Melanoma Conference, which took place last week in Banff, Alberta. To give us this comprehensive review, we have honor to welcome our highly esteemed Dr. Michael Smylie. I will hand over the introduction to Kathy in just a moment, but first off, a few logistics. All participants in the audience for today's webinar will be in listen mode only for the duration of the session. If we have time, there will be a question and answer portion at the end of the presentation. To ask a question, please type in the Q&A panel, which you can access at the bottom of your screen. Please feel free to ask your questions throughout the presentation, and we will do our best to answer them in the last segment. If there are any questions that do not get an immediate answer, we will contact you with a reply and any discussion you wish to have after the webinar. This session will be recorded and will be available for viewing in English and French on the Save Your Skin Foundation website and our YouTube channel. We will send the recording to everyone who has registered tomorrow. Pour ceux et celles qui voudraient entendre cette présentation en français, veuillez simplement cliquer sur l'icône Interprétation au bas de votre écran et sélectionnez le français. Par défaut, vous entendrez l'interprète à 90% du volume et l'audio original à 20% du volume. Si vous souhaitez déactiver ou réactiver le son d'origine, cliquez sur l'option Couper le son d'origine, Mute Original Audio. Okay, thanks again for joining us, and we will now begin the presentation. Here's Kathy Bernard, our founder and president of Save Your Skin Foundation, who will now say a few words and introduce Dr. Smylie. Kathy, the floor is yours.
Thanks, Jasmine. Well, it's always my great honor to introduce Dr. Smylie. Save Your Skin Foundation probably wouldn't be here if it hadn't been for him. Dr. Smylie is currently appointed as professor in the Department of Oncology and the Faculty of Medicine at the Cross Cancer Institute in Edmonton, Alberta. He is the site leader, Clinical Trials Committee, Cross Cancer Institute, NCIC Melanoma Group leader, and very, very active in designing and participating in melanoma and non-melanoma. He is instrumental in new drug development in melanoma and non-melanoma, and he has chaired several national melanoma meetings and organized national melanoma conferences in Canada. Dr. Smylie has been a great friend to Save Your Skin since we started in 2006. So without further ado, over to you, Dr. Smylie.
Well, thank you, Kathy. It's a great honor to be here, and welcome everybody. So I think we're going to start sharing the screen here, if that's okay, and then okay, it's all good. Okay, so it was an honor to attend the 17th Canadian Melanoma meeting again. This is our, this was started back around 1995-96 as the Canadian Western Melanoma meeting. And back in those days, it was pretty primitive to what we have now. And it actually was really hard to get enough material to talk about. And when we decided to make it an annual meeting, we ran into difficulties because there really wasn't enough things happening in melanoma to have it every year. So we used to alternate between October and January and do it every 18 months. But now there's so much information, and a year doesn't even seem a short enough time to get everything together. So what I want to do is just go through some of the history of melanoma, like where we were pre-2010, and the advances we made, and then just kind of use what was presented at the conference and put it into perspective of where we are now and where we're going. So back prior to 2012, when I started treating melanoma in 1995, we didn't really have a lot of options as far as therapy goes. We had cytotoxic chemotherapy, and the only drug that was approved, the only chemotherapy drug that was approved was dacarbazine, which was approved in 1975 on some very small studies. They're called phase 2 studies, so there's no control group. And it showed a response rate of about 15%, which when I trained, 15% was the cutoff. If you were below 15%, they said the drug wasn't active. If you were above 15%, they said it was active. So it said a response rate around 15%, and the FDA at that time was not as stringent. They thought we really don't have anything else, and so they approved dacarbazine. But as time went on, we saw dacarbazine was not as active as we thought it was, and they even questioned whether it was really much more than a toxic placebo. Despite that, we went over 45 years before we actually had a positive study and anything was shown to be better than dacarbazine. Temozolomide is essentially just an oral equivalent of dacarbazine. It wasn't, it was not approved by the FDA and not approved by Health Canada. They thought that because it crossed the blood-brain barrier, it would be superior to dacarbazine, but it failed to meet its primary endpoint of improvement in survival. It looked equivalent, so they filed to the FDA and Health Canada on equivalency, but they refused it because they said the trial was not designed for equivalency, it was too small. When I started, we used combination chemotherapy. So the Dartmouth regimen was 3 chemotherapy drugs plus high-dose tamoxifen. It was based on a very small sample size, and the first 20 patients had about a 57% response rate. But unfortunately, as time went on, the response rate started to come down, and then an intergroup trial compared combination Dartmouth versus dacarbazine. And there was a higher response rate, but survival was not different. And likewise, CBD, which was a triple regimen from the MD Anderson, was also shown being to non-superior in survival to dacarbazine. So for 45 years, we were stuck with this drug. Interleukin-2 was approved in 1998 based on, again, the cytokine working group of about 130 patients. It had response rates, again, around 15%. But the difference was that when you got a response, they appeared to be more durable than what we got with chemotherapy. In the 1990s, we started combining chemotherapy plus interleukin-2 and interferon. Again, phase 2 studies were looking promising, but the randomized phase 3 studies were all negative for survival. So for the 40 years between 1975 and 2010, the standard of care at any academic center was always a clinical trial. Melanoma was a very tough tumor to treat. It was felt to be inherently resistant to all chemotherapy drugs. Back in those days, neither immunotherapy with interferon or interleukin-2 had failed to show consistent overall survival. So this was a really sobering trial. So this was published in 2008. And this was a data on over 2,100 patients, stage 4 patients who were treated on clinical trials. And it showed that the median overall survival was 6.2 months. So that at 6.2 months, half the patients with stage 4 melanoma had passed away and half were still alive. Only 25% survived to 1 year, and only 10% were alive at 20 months. So it's pretty dismal. And the FDA actually called a State of the Science meeting because they said we've made no progress in this disease in the last 50 years. In fact, you could probably argue that we had not made any progress in this disease. So everything changed in 2010. So then this has largely come about by targeted therapy. So this was first published, shown that melanoma is a highly mutated tumor. And we now have targeted therapy, so the so-called designer drugs, and we got immunotherapy. So if you look now at what drugs we have, like in 1975, we had dacarbazine, then we had high-dose interleukin-2, then we got our first CTLA-4 our first checkpoint inhibitor, ipilimumab, our first BRAF targeted therapy in 2011 were approved. It was actually 2010 that we saw the results. Then we got the combination drugs, and we got combination of PD-1, and then we got PD-1 plus CTLA-4. TBEC, which is an oncolytic vaccine, was only approved by the FDA. Their phase 3 trial was negative, and so it's unlikely to be approved in Canada. The approval may be withdrawn in the US too, depending on what the FDA decides. And the new kid on the block, which I'm going to talk about later, the encorafenib and binimetinib, and then triplet therapy. So, oh, sorry, I just want to show that. So the 6-year overall survival now is about 50%. So we've gone from less than, in 1975, if you look at the chemotherapy drugs, the survival at 5 years was less than 5%, and averaged around 2 to 3%. Now it's 50%. So in the CMC updates, cancer advocacy, targeted therapy, immunotherapy, how to sequence these drugs, the new kid on the block, the LAG-3, ocular melanoma, and the microbiome. So of course, everybody knows Kathy because she's chairing this meeting. Kathy has been an incredible person. And when I walked into one of the meetings, Marcus Butler said to me, man, he goes, you saved the best person here. Like, she's just incredible. And she's done so much for cancer advocacy. And I think a lot of what Kathy does is behind the scenes work. A lot of times they try to defund drugs and they refuse to fund them. Kathy goes to bat for us, and she almost always gets funding for our drugs so that the melanoma patients can have access to it. Kathy had 2 talks. She opened up the meeting, and then she also was on a panel discussing therapy. So we know that melanoma is the most mutated cancer of all the cancers. So it's got a what we call a very high tumor mutational burden. But most of those mutations we think are just background noise. They don't have any clinical significance to the growth of the cancer cell. But there's a few key mutations that we call driver mutations. And you almost always only see one driver mutation per cell. And so if you can identify a driver mutation and then design a designer drug to knock out that mutated protein or enzyme, then you should be able to get high response rates. So if you look at some of the key mutations, I think the big one that people talk about, is BRAF. So about 40 to 45% of patients in Canada have a BRAF mutation. Higher in some areas like in sort of more northern latitudes where you get intermittent exposure to the sun. NRAS mutations are present about 15%. And NF1 mutations are quite interesting. They're about 14%. And a rare type of melanoma called a desmoplastic melanoma, which just basically looks like scar tissue, has a very high incidence of NF1 mutations, and it appears to be the most sensitive to anti-PD-1 therapy, so immunotherapy. So that this is actually quite interesting here. And then the PI3 kinase pathway also is highly mutated in melanoma, absence of PTEN, which is a tumor suppressor gene, and then the TERT promoter, and then the cyclin-dependent kinase pathways, which are involved in melanoma growth, are often mutated. And in ocular melanoma, the GNAQ and GNA11 mutations that are present in about 85% of the ocular melanomas. So to date, we only have really 4 targeted mutations that people have had success in trying to block. So c-KIT mutations are present, they're mostly seen in ocular mucosal or acral lentiginous melanomas. And so if you do have a c-KIT mutation, then you can look at c-KIT inhibitors such as imatinib, dasatinib, or nilotinib. And so although these drugs were never approved in Canada, that now that they're off the high cost drug list, they are available to us. We don't have to have director's privileges because there's generic versions of them now, so they're quite cheap, so we can access these drugs in patients who have c-KIT mutations. The second is the NRAS mutations, and really they tried MEK inhibitors, but it hasn't really been successful in trying to target the NRAS mutations. The NF1 mutations I already talked about, present in a high preponderance of desmoplastic melanoma, and seems very sensitive to immunotherapy, PD-1 therapy. And the BRAF mutations are really where we've had the most success. Most mutations are what we call V600E, and there's V600K. But there's also other mutations that are rare that people are looking at to see if the targeted therapy works on those patients. There's also the second generation BRAF inhibitors coming out too that are in early phase trials. So they seem to be more potent than the first generation BRAF inhibitors. So keep your fingers crossed, we'll see better success with the targeted therapy down the road. So this is the BRAF pathway, and this was the first targeted therapy to be approved. So this was a drug company called Plexicon. The drug is now known as vemurafenib. And when this phase 1 study was done, when they got to their phase 1 dose, which is the dose they want to take forward to check to see if the drug really works, they did an expanded cohort of 30 patients that had an 82% response rate. So everybody was, and they actually started to talk about something called the Lazarus effect. Like, it was just incredible. People who were in palliative care were getting this drug, and 10 days later, they were walking out of hospital. So everybody was ecstatic because we thought we had this miracle treatment for melanoma. But this was a paper that was published by Nathan Weigel and JCO in 2011. And you can see the first patient, you can see this young man with widespread subcutaneous metastasis, so just under the skin. You can see that sometimes in melanoma, when you get very high volume disease, you actually get pigment deposition in the skin. It's kind of this funny grayish brown color. It doesn't look like tan skin or pigmented skin. It's kind of got sort of a bluish tinge to it. And you can see that he's got this melanosis. And then at week 15 in the second photograph, you see he's had this dramatic response to BRAF targeted therapy. But by week 23, he's pretty much back to where he started from. And he unfortunately passed away a few weeks after this picture was taken. So a lot of work, especially at this meeting, is focused on drug resistance. And how can you overcome resistance to BRAF inhibition therapy? And there's two major pathways. There's a MEK-dependent progression, and the second pathway is MEK-independent. So I always tell patients that this pathway is kind of like dominoes, that one activates the next, and then the next, and the next. And so if you see that BRAF activates MEK, which activates ERK, which drives the cells to grow and not go through programmed cell death. So most resistance occurs by bypassing the mutated BRAF and activating MEK directly. So they looked and said, well, what if we add a MEK inhibitor plus a BRAF inhibitor? And we saw that not only did we get increased response rates and longer survival, we also generally saw less toxicity, especially skin toxicity. So there's 3 randomized trials, and there's the COBRIM, COMBI-D, COMBI-V, and the Columbus trial. And the Columbus is the newest one on the that's been approved. So I want to spend just a little bit of time talking about the Columbus trial and what that has meant to therapy. So this was a Columbus study design. So as I said, they were the last of the races. So it was kind of a little bit tougher because all these other targeted therapies were getting approved. So they looked at their targeted therapy, encorafenib plus binimetinib, versus encorafenib, because they didn't have an approval by Health Canada for single agent encorafenib. And you can notice that the dose is lower here. Is 300 milligrams. This was the maximum tolerated dose as a single agent. You can see that when you combine it with a MEK inhibitor, you can actually give quite a bit more, like 50% more drug. And vemurafenib was the control arm. The primary endpoint was the progression-free survival. And this was by a blinded independent central review. So all the scans were sent to central review, and they were reviewed independently. So this is a 5-year progression-free survival. So you can see that clearly in favor of the combination therapy. So 22.9 months at 5 years versus 19.3 versus 10.2 for vemurafenib. If you look at the overall survival, about a third of patients are getting long-term overall survival. So 33.6 for the combination, 23.5 for encorafenib, and 16.9 for single agent vemurafenib, which was the control at the time. So if you look at the summary of targeted therapy trials, so we've got 3 options to use. And so people say, well, is one better than the other? And there's a lot of enthusiasm about the Columbus because encorafenib has a very long half-life of about 23 days. And so as opposed to a BRAF inhibitor that has a very short half-life, the encorafenib offered the possibility that you would have complete blockade of the BRAF receptor. So early on, if you look at the progression, the median overall survival looked a little bit better. It was 33.6 versus 25.6 for the dabrafenib trametinib versus 22.3. But if you look at the 5-year overall survival, pretty much the same between all 3 regimens. So I think when you're choosing a regimen, this one has an incredible amount of skin toxicity. So as David Hogue used to say, when you're on the vemurafenib and cobimetinib, he tells his patients you basically have to live like a vampire. You have to avoid the sun because your skin is very photosensitized, and you can even get a sunburn just through the windshield or reflected sun off the snow. The COMBI-V, the dabrafenib with trametinib, big problem is pyrexia or fever. And if you look at the Columbus trial, you might see a bit more nausea, and there's increased, they did see increased ocular toxicity. Well, there's a question whether or not this is real or not, or if it's just that the trial mandated regular ophthalmologic assessments. But it seems to be a little bit better tolerated is what people's experience says. So this is the median overall survival. Notice again, I think this was the most important study, and we spent some time on this study discussing new endpoints, and this study has really been analyzed to death. But I think this was probably the most important study in melanoma to date. And certainly in my career spanning 25 years, we had a big participation in this trial. And then this was the most important trial that I ever participated in. So this was the Checkmate 067. So this time they had a PD-1 inhibitor, the nivolumab. Ipilimumab was the first checkpoint we had, is a CTLA-4 inhibitor. And so you have to understand that these drugs work through different mechanisms of action. If you can, the ipilimumab works at the primary phase, so it works in the lymph node. So it's where the tumor cell antigens are presented to the immune cells in the lymph node. Then the immune cells start to multiply, they leave the lymph node, and they hopefully travel to the tumor. PD-1 works, they're like the linemen in a football game. They're right down in the trenches, so they work right at the level of the tumor. And they, when T cells are activated, so the immune cell, as soon as you turn it on, you have to turn it off. And so as soon as the immune cell is activated, it starts to deactivate. And it does that by producing checkpoints. So CTLA-4 is produced in the lymph node, and the PD-1 is expressed at the level of tumor. So when you see a lot of PD-1 expression on the T cells, you know that they've been activated. Later on, you'll see other checkpoints such as TIM3 and LAG3, which we're going to talk about later. So this is a trial between nivolumab plus ipilimumab. I would say medical oncologists are not rocket scientists, that if you have two good drugs, then the combination of the two has got to be better than one drug alone. It was compared to nivo versus ipi. And unfortunately, the primary endpoint of this trial was the progression-free survival, but it was really to compare the two nivo-containing arms to the ipi. There was a descriptive analysis between the combination versus nivo alone, but the trial was not powered to show a statistical difference between the two, which is what everybody really wanted to see. So this is the overall survival. So we now have 78 months of follow-up. You can see that these curves, what's really important, so when you look at checkpoints, and I always tell people that when you look at immune therapy, you don't look at the median overall survival. What you really want to look at is the tail of the curve, because you can see that at about 3 years, these curves plateau. So they're going flat. So this is what we always want to see in oncology, because this means that these patients are getting long-term survival, and probably even most of these patients are probably being cured of their stage 4 melanoma. So you can see that at 5 years is 52%, 49%. And the ipilimumab does not fare as well, 26%, 23%. And the nivolumab, better than ipi, which we already knew, but not as good as combination therapy, so 44 and 42%. So when you look at overall survival, if you follow survival curves long enough, we're not tortoises. So eventually these after 50 years, these curves are all going to go to zero. So what you want to, what a lot of people are looking at now is these patients that are alive at 5 years and are dying after 3, 4, 5 years, are they dying of melanoma, or are they dying of other causes like other medical conditions? So if you look at the melanoma specific survival, and this just looks at people who die from melanoma, you can see that these curves are pretty well flatlining for the combination therapy. So 57 versus 56, 50 and 48, and 30 versus 27. So just amplifies that if you're cancer-free at 5 years, it's unlikely that you're going to die of melanoma if you're alive at 5 years. So this was the overall survival by the best response. So we know that patients who get a complete response are going to do well. So if you get your ipilimumab and nivolumab, and at 4 months or 3 months when you get your first assessment that there's no cancer seen, that's what we call a complete response. We know those curves flatline, and your long-term survival is excellent. So complete responders at 5 years, 88%, 79% for the partial responders. A lot of these partial responders are probably, some of them are certainly complete responses, but sometimes on the tumor imaging, it doesn't all disappear. But sometimes if you biopsy that tumor, do a PET scan, you see that these tumors are dead. The ipilimumab is not expected, it doesn't do as well. Or for the stable disease and progressive disease, sorry. So we also talk about the treatment-free interval. And this is important because when you're on targeted therapy, you have to take pills every single day, like twice a day. And there is no evidence they can actually stop these pills. So we just tell patients that you take the pills for as long as you tolerate it, and as long as it's working. So this is looking at the treatment-free interval. So basically, the treatment-free interval is the time from completion of your first therapy to the start of the next therapy. So you can see at the nivo-ipi, 27.6 months. Nivo is 2.3 months, and the ipi is 1.9 months. So if you look at patients alive and treatment-free at 6.5 years, again, superiority for the combination. So 77% of patients who were alive at 5 years had not received any further systemic therapy. So that's important because patients, when you got cancer, is that I remember one of the cancer patients tell me several years ago that he said, living can be a tough thing sometimes. And when you're getting a treatment that's difficult, it's really impacts your quality of life. So if you look at nivo/ipi, it's a short treatment. The average number of cycles in the 067 was 4. And so if you look at these patients, like the patients who are alive, 77% have never received any further therapy. Nivo is pretty impressive at 69, and the ipi is not quite as good at 43%. So in summary, I think this just accentuates the fact that the 067 trial is as impressive as the first time we saw the first analysis. Treatment-free survival is quite impressive, with 77% of patients alive or who are alive treated with ipi/nivo still treatment-free. No new safety signals were identified with longer follow-up. So we know that targeted therapy gives high response rates. Immune therapy gives lower response rates, but gives more durable responses. So people say, well, what if we combine both? Like, what if we add in targeted therapy plus immunotherapy? Can we get the high response rates of targeted therapy and the durability of immune therapy? And these were the 3 trials that were done. Only one trial was positive. I always argue that it was only positive because of statistical design. And it was approved in the US, but not approved in Canada. And when Lex Egermont was out, he said, if you look at the difference between the BRAF MEK inhibitor versus the triple therapy, the difference was 15 days. So not very impressive. It is much more toxic when you use triple therapy. You see a lot more hepatotoxicity, and there's more grade 3, grade 4 treatment-related side effects. And so I don't think there is really a place for triple therapy in melanoma. But Carolyn Robert talked about this, and she said that she rarely would use triple therapy, but she said for patients who have very rapidly progressive disease with high lactate dehydrogenase, we know that those patients are less likely to respond to immunotherapy, but their responses to targeted therapy, although good initially, tend to be very short lasting. So in those patients, she might consider it, but in most of her, probably 90% of her population, she would not use triple therapy. And I think this is how most people are feeling now. But despite that, in the US, when this therapy was first approved, there was a lot of oncologists that were offering this to melanoma patients. So how do we sequence these drugs? So they spent a lot of time talking about how to best sequence these drugs. And at this meeting too, there's a lot of people talking about, especially Carolyn Robert, where do we use these drugs? What comes first and what comes second? So this was a paper that was published in 2017. And you look at the survival curves of chemo versus BRAF versus combination targeted therapy versus CTLA-4 versus PD-1 versus the combination. You can see that there's an early survival benefit for the targeted therapy because it's got very high response rates. Pretty well everybody responds. But we know that with high volume disease, high lactate dehydrogenase, most people progress. And so after about 1 year, the curves start to cross. If you follow it out to over 2 years, you can see that the superiority is clearly in favor of immunotherapy, particularly CTLA-4 plus PD-1 together, followed by PD-1. And so the clearest superiority in long-term survival is with immunotherapy. But these were not head-to-head comparisons. These were just inter-trial comparisons. So it's really just what we call hypothesis generating. So this was a trial that was presented that tried to test this concept. So we know that targeted therapy has the high response rate. So they randomized patients to targeted therapy, encorafenib plus binimetinib, until patients progressed, and then they received ipi/nivo until progressive disease. The primary endpoint was overall survival. Arm B got combination immunotherapy, so ipilimumab and nivolumab, that was the big criticism of the triplet trials earlier, was that they used BRAF MEK inhibitors as the control arm. And people later on came back and said, well, that's really not the standard of care. in 2022, the standard of care is ipilimumab and nivolumab. So this had what we call the so-called standard of care arm. Arm C was a sandwich. So it looked at a short induction period of 8 weeks of encorafenib plus bendamustine. So we know that targeted therapy can have very dramatic responses and very early. So you can often see responses within the first 1 to 2 weeks. And so we also know that targeted therapy causes upregulation of tumor antigens, causes migration of immune cells into the tumor microenvironment. So there's a lot of immunological effects. So they said, well, what if we treat for 8 weeks and then do that switch? Switch them over to ipilimumab and nivolumab. And if they progress, then they can receive encorafenib and bendamustine. Now, unfortunately, this is not practical in Canada, because if we start off with targeted therapy and we switch them over to immunotherapy, we are not allowed to use targeted therapy at progression because they said, no, they've already had targeted therapy, so we're not going to pay for it. So you have to be a little bit creative in trying to get this funded. But usually we can sort of get these drugs funded, but it is tricky to get them funded. So this was looking at the progression-free survival. What's interesting, so if you look at the arm A, which is the targeted therapy, 1 year, we saw pretty similar progression-free survival, a little bit better than the immunotherapy arm. But if you look at 2 and the 3 year, you start to see that the 3-year progression-free survival falls for the targeted therapy, but is improved for immunotherapy and for the sandwich technique. Likewise, if you look at overall survival, pretty good at arm 1A and B, but if you look again at 2 and 3 year overall survival, you start to see this clear superiority for immunotherapy introduced early, as opposed to targeted therapy till progression. So in this study is clearly, and it's interesting because 5 years ago at this meeting, it was pretty well a 50-50 argument on whether or not you should start with targeted therapy versus immunotherapy. And our center in Edmonton was always an immunotherapy center. We always did first-line therapy, but you know, I always did it with a little bit of hesitation because we know that there can be life-threatening toxicity sometimes with immunotherapy, and the endocrine ones are irreversible. So if you treat a patient, they get diabetes, you know, it's lifelong, it tends to be quite brittle. You feel very guilty about it, and you start to think, well, in retrospective, I'd given them targeted therapy, wouldn't have diabetes, but now we're starting to see clear evidence that starting off with immunotherapy or a short induction of targeted therapy followed by immunotherapy is clearly becoming superior. So this is just to summarize. So I think the evidence for ipi-nivo first line is solid now. The single agent PD-1 for first line therapy for those patients not eligible for combination immunotherapy. Targeted therapy, I think Alex Menzies made an interesting comment, which I always thought agreed with. But so he says targeted therapy to him is salvage therapy. So this is used in patients who progress on immunotherapy. But despite that, we know that most patients will ultimately develop disease resistance. But we all have those cases of patients who got immunotherapy, and then they progress on immunotherapy, and then they get these dramatic long-term responses to targeted therapy. Now, the question that comes in, Vern Sondag was talking about his one patient who progressed on 2 cycles of ipi-nivo. They gave them targeted therapy, and 29 months later, they're still in a complete response. The thing you don't know is that we know that with immunotherapy, you can get late responses. You can also get something called pseudo-progression. So the tumor actually looks like it's growing before it starts to shrink. So these durable responses may be due to targeted therapy, or it may be due to a late response from the immunotherapy. Triplet therapies I mentioned should be possibility for very rare patients, but I've never used triplet therapy outside of a clinical trial, and I can't see an incidence, well, maybe 1 or 2 cases where I would consider it, but we don't have it approved in Canada. So what we spent a lot of time, so Alex Menzies talked about this whole concept of what we call neoadjuvant therapy. So these drugs were all approved in stage 4. So stage 4 melanoma patients are patients who have no surgical options of cure. There was no curable options for treatment when these patients were first entered onto trials. And so these drugs, you get some proof of concept, and then you usually get a notice of compliance or an FDA approval from the regulatory agencies in stage 4 disease. So with stage 4 disease, and you start to take these drugs and you say, well, what if we use it in patients in earlier stage melanoma? Can we decrease the number of patients who are developing stage 4 disease? And long-term, can we improve survival of melanoma patients? So if you look at this study, so we know that if you look at the pembrolizumab versus placebo, you can follow the survival. Pembrolizumab has clearly shown to be better as far as relapse-free survival goes. We've got 4-year follow-up now. There have not been enough events to look at survival. But if you look at this therapy, so when we use adjuvant therapy, these patients here don't need adjuvant therapy. They never recur. And so we're treating all these patients unnecessarily, possibly giving them long-term toxicities when we're never going to recur from their cancer. This group of patients are going to recur despite getting a drug. So the drug really doesn't improve their cure. And so there's a small population, so about 20% of patients who actually benefit from therapy. So when you're looking at a stage 3 population, 80% of your patients are not benefiting, 20% are. And this has always been the dogma of oncology. It's been you're treating all these patients for that small little benefit in survival, but you don't have that crystal ball that will tell you who's going to benefit, who's not. We're getting there. There's a lot of stuff looking at NGS and sort of looking at gene profiles and stuff to try and predict who needs adjuvant therapy versus those who don't, but we're not there yet. In breast cancer, they have the Oncotype DX score that can help you predict who's going to benefit from chemotherapy versus those who don't, but we don't have that yet in melanoma. So unfortunately, all patients get treated. This therapy is not cheap. It's about $100,000 US per year. It's a lot of time for the patients. They have to come to clinic every 4 weeks or 3 weeks, depending on what you use. They're getting a lot of CT scans like every 3 months. So is there any other way? So what about if we give immunotherapy before treatment as opposed to after surgery? So this is called what we call neoadjuvant. So the advantages are it's a shorter treatment. It's a tailored prognosis. So these are in patients who have had melanoma and they relapse with what we call macroscopic disease or palpable lymph nodes. So if you had a melanoma on your arm, you get a lump in your axilla, it's biopsy shown to be melanoma. That's what we call macroscopic disease or palpable adenopathy. So what they're asking is that if we give treatment before surgery, so the standard of care right now, if there's no signs of distant metastases, is a complete lymph node dissection. So what about if we give a shorter treatment? We can see if the treatment actually works. And if it doesn't work, then we have that option to switch to something else. So if you start with immunotherapy, it doesn't work, we can switch to targeted therapy. So the disadvantage is that some patients may progress. And it's occasionally they're distant metastases, and it is more toxic with the combination therapy. So they've also been shown that neoadjuvant therapy may actually decrease the frequency of surgery for patients. So if you sample a lymph node, so it's called the index lymph node. So if you take the largest lymph node, you put a bead in it, and you give them immunotherapy, that there is trials that suggesting that those patients who get a major pathological response, they may not need to have a completion lymph node dissection. And the completion lymph node dissections in the arm are not so bad, but in the groin, there's about a 60% what we call morbidity. So it's either lymphedema and post-op wound infections or wound breakdown. So there's a lot of morbidity associated with a groin dissection. The arms are not as bad, but there's still a risk of lymphedema, ongoing chronic pain, numbness, neuropathy, and stuff. So if you can avoid surgery, that's a good thing. And it also allows us to trial new drugs. So you can test these drugs, and it's faster and cheaper to see if these new drugs add a benefit or not. So this was a previous trial that was done. This is old, but just showed that if you get a complete response, that the chance of getting a complete response is better with combination therapy than with monotherapy. So the standard of care going forward is what we call ipi-light. So ipilimumab at 1 milligram per kilo as opposed to 3, and nivo at 3 as opposed to the 1. So if you look at the pathological response, so this was presented by Christian Blanc, this is the Opass and Neo. you can see that the overall response rate, 71%, so pretty impressive. We had about a 58% with metastatic disease, and the pathological response rate is 61%. So 50% of patients had a complete pathological response. So when they took out the index lymph node, they could find no evidence of cancer, okay? Those patients, if you follow those patients for 2 years, they have excellent outcomes. Hardly any, is very rare to recur at 2 years. Or a near pathological response where there's 10% or less viable tumor cells, and there's a partial response, and then some patients have no response and other patients progress. So this was the Prado, and this was the trial I was talking about earlier. So those patients who had a pathological CR, near pathological CR. This was a phase 2 study. So they did not get a completion lymph node dissection, and they had follow-up CT scans and ultrasounds every 12 weeks. And if you see their 2-year survival is excellent. So for those who had a partial response, they had their total lymph node dissection, did not receive any further adjuvant therapy. And those who had no response had a total lymph node dissection. They either went on to nivolumab, or else they could have had radiotherapy or targeted therapy. So these patients only got 2 cycles, so 6 weeks of treatment. And in Canada, so the first time you see your surgeon until the time you get your surgery, it's going to be 6 to 8 weeks anyhow. And and with COVID, it's probably a little bit longer. So it really wasn't delaying surgery. So 2 cycles before surgery, and you got your index node taken out, and then you could judge your therapy from how you responded. So this is the new kid on the block, nivolumab plus relatlimab. So nivolumab, we know, is the PD-1. Relatlimab is a LAG-3. And I was always a bit skeptical of this, because when you see LAG-3 and PD-1 expression on the T cells, you know that those T cells are very exhausted. And I was kind of not very optimistic that these exhausted T cells could be rejuvenated. But this looked at neoadjuvant relatlimab plus nivolumab. So this was given in fixed doses, 2 cycles, had their CT scan to assess for response, that's had their surgery. And then they went on to adjuvant therapy until clinical progression. Okay, and you can see that the overall response rate is 79%. So pathological CR was 59%. But as opposed to ipilimumab and nivolumab, there's a lot less toxicity. So about a 25% decrease in the grade 3, grade 4 toxicity rate. So this was the S1801 study schema. This looked at resectable stage 3B, 4 patients, and they're randomized after surgery, or one arm was randomized after surgery adjuvant therapy. So they got 18 cycles of pembrolizumab. The second arm got 3 cycles of pembrolizumab. Then there's surgery, and they received 15 cycles of pembrolizumab. So if you look at the event-free survival, which was their primary endpoint, 72% for the neoadjuvant as opposed to 49% adjuvant. So that's an incredible difference. So 23% difference between the 2 arms. So the follow-up is short, it's only 2 months, or two years, sorry. But longer term follow-up and the larger studies will show us if this really is going to be better than adjuvant therapy. So if you look at the overall survival, you can see that the hazard ratio crosses 1. So this is not met statistical significance. You can see that there's a trend, and the trend just means that it's not statistically significant, but it looks better, okay? So with longer follow-up, hopefully we'll see that survival curve become statistically significant. So we had Arjun Sehgal talk. He's a radiation oncologist from Sunnybrook. And we had Arjun out, I invited Arjun out about 6 years ago, and I invited him to Edmonton because at that time, about patients who developed brain metastasis and melanoma had a horrendous survival. And it was really a horrible quality of life. And so there was an Australian retrospective study that showed that patients who had brain metastases, their median survival is between 3 and 4 months, whether or not you gave radiation or not. The difference in survival is only about 1 or 2 weeks. And so radiation was largely viewed as a palliative treatment. Melanoma is felt to be a radiation-resistant disease, but the knee-jerk reaction for anybody on brain metastases, if they weren't surgically resectable, was whole brain radiation. And then most patients died within 3 months of radiation. So this was the ABC study, an older study, but it just showed us that it looked at in patients with asymptomatic brain metastases, less than 4 centimeters in size and less than 4 metastases, then they were randomized to either Nivo plus Ipi or Nivo alone, or those patients with leptomeningeal or MRI progression on steroids received single agent nivolumab. And I think the important thing you want to look at is look at the 5-year survival for patients with brain metastases treated with Nivo plus Ipi, 51%. So almost exactly what we see with systemic disease. So systemic therapy here now offers us the opportunity of getting long-term disease control. Clearly superior to the Nivo, much better than the patients with symptomatic disease and on steroids. So it was interesting to hear, Arjun and I were having supper after his presentation. We were laughing about when he first came out versus when he came out this time. So now in patients, we've used very little whole brain radiation in melanoma now. So most patients who have brain metastases get stereotactic radiation. We do very frequent imaging of these patients to follow them. So patients will get MRIs every 3 months. If they have any new lesions or progressive lesions, they will get stereotactic. And we try to avoid whole brain radiation because it really affects your cognitive abilities, especially if you're going to be a long-term survivor. And it's the quality of life is decreased, a lot of fatigue, a lot of symptoms. So we try to avoid whole brain radiation, but unfortunately there's a few instances where we just can't avoid it. So where are we going? So I think the melanoma treatments of tomorrow we're just really scratching the surface of immunotherapy combinations. So there's checkpoints, there's probably at least over 100 checkpoints. Some are agonists, some are antagonistic. So some, if you activate the checkpoints, they will stimulate the immune system. Others are negative stimulators. So if we block those, you can activate the immune system. So they're looking at LAG3, TIM3, there's CD40, and there's a whole bunch of GITR and a whole bunch of new checkpoints that people are looking at. Most of these are in phase 1 or phase 2. You can also look at the tumor microenvironment. So the tumor microenvironment is either hot or is cold. So sometimes when you put a fluorescent label on a T cell and you inject it, the T cells go right into the tumor, and other times they head to the tumor and then they stop right at the edge. And it's like they're afraid to go in. And we call those cold tumors. And the tumor microenvironment is very hostile. So there's a lot of research looking at how do we manipulate the tumor microenvironment and get the T cells to move in. So this is LAG3 that we talked about before. It's a lymphocyte activation gene, again, expressed on activated T cells. And usually when you see PD-1 plus LAG3, you know that the T cells are coming to an exhausted state. So this was a study tested in metastatic disease. Again, the same doses that we talked about in the neoadjuvant setting, Nivo plus relatlimab versus Nivo alone. Primary endpoint was progression-free survival. You can see that the progression-free survival is clearly superior for the combination versus Nivo, so 10.22 months versus 4.63. So interesting, very similar to what we're seeing with Ipi-Nivo, but the toxicity is far less. We look at overall survival. Question about patients who have PD-L1 less than 1% or greater than 1%. So I think that all subgroups seem to benefit, but there's no clear indication which subgroups we should use it for. What about ocular melanoma? So ocular melanoma has always been that Pandora's box of melanoma. We made all those breakthroughs in cutaneous melanoma, but ocular melanoma patients were excluded from those immunotherapy trials. They're excluded from almost all trials of melanoma because it's just felt that ocular melanoma is different, it's more resistant, and it doesn't seem to have the same immunological responses. So if you look at a skin-induced melanoma, so if you get a melanoma in your back or a sun-exposed area, they typically have a very high tumor mutational burden. They have that classic ultraviolet signature, and they're more likely to respond to immunotherapy. If you look at the ocular melanomas, they're at the other end of the spectrum. They have a very low tumor mutational burden, and they don't have that ultraviolet signature, and they just don't seem to respond as well to immunotherapy. So this was a meta-analysis that looked at those patients who had metastatic uveal melanoma. You can see that their survival is actually very poor. So there really, up until recently, there really wasn't any drugs that were shown to improve overall survival in uveal melanoma. We used a lot of immunotherapy in these patients, but These patients, as I said, were excluded, but in the access program, they were allowed. There has been some small phase 2 studies that suggest that ipilimumab and nivolumab has some patients will respond. But I think the long-term survival is clearly inferior to what we see with immunotherapy. So this was a new drug that we just got access to within this last year. And this was presented by Dr. Marcus Butler. And this was looking at a drug called tebentafusp, or Kimtrak is his trade name. So there was 2 studies. There was this phase 2, and then there was the randomized study. And this was using something called a bispecific antibody. So this is an antibody that's got 2 active sites on it. So it grabs the T cell and hooks onto the tumor cell, and it pulls the T cell into the tumor. And so it's a bispecific antibody. The phase 2 showed some encouraging responses and some durable responses. So in this randomized study, they took patients and they had to express GP100, which is a melanoma differentiation antigen. So it had to be HLA-O201 positive, okay? So these patients expressed the GP100, and obviously you have to express the GP100 for this bispecific antibody to bind to. This is about 40 to 45% of the population. They were not allowed to have any prior systemic therapy, no prior liver-directed therapy except surgery, and they were allowed to have an elevated lactate dehydrogenase. They're randomized 2-to-1 to either escalating doses of tebentafusp. So when you give tebentafusp, you see a lot of cytokine release syndrome. But after about day 15, after the 3rd or 4th dose, this seems to really abate. So they escalate the dose. They start off at 20, then they go to 30, then they go to full dose 68. And this is versus investigator's choice. So you used a carbazine, which we know is a placebo, ipilimumab, or pembrolizumab. The majority of patients got pembrolizumab, sorry. So this is the overall survival. So clear survival benefit in favor of the tebentafusp. So 21.7 months versus 16 months for the investigator choice. And so this drug was recently approved by Health Canada and is now available for our ocular melanoma patients. So first line has the best survival benefit, but there's also evidence that second line therapy is also good. Tebentafusp heats up the tumor site, so it's possible that after tebentafusp, immune checkpoint therapy could work better following tebentafusp when it's given first line, but that's just anecdotally. And I think that this needs to be really tested more formally in prospective trials. So in conclusion, uveal melanoma has been a very difficult tumor to treat. I always used to have to take a deep breath when I had a metastatic ocular patient because you know that the treatment is unlikely to be successful. At least now with tebentafusp, we have some hope in those patients who are GP100 positive. Okay. So the last thing I want to talk about is the gut and the immune system. You probably have seen a whole lot of stuff about what we call the tumor microbiome. So every one of us is born sort of devoid of microbial colonization. But as soon as we're born, we get exposure to a whole new microbial world. The gut has the largest diversity and abundance of microbes. There is about 100 trillion organisms in our gut, so more cells than our body has. Most are bacteria. The collective genome or the metagenome of the GI microbiota has about 100 times that of the human genome. Each individual is populated by about 15% of the 1,000 more species of intestinal bacteria that have been described. So we have about 10 times more genes in our microbiome than we do. And they're encoding the greatest source of antigens for our immune system. And it's really a symbiotic relationship. They live off us, so they get nutrition, a warm place to grow. We don't feed it very well, but they get the host environment, and from them we get adaptation of our immune system, and it prevents things like diabetes, hypertension, and we get a very highly adaptive metabolic engine. So this is evidence from the animal model. So if you take mice and you treat them with high doses of antibiotics and sterilize their gut, then you can grow human tumors in these mice. Then you treat them with checkpoint therapy, it doesn't work, okay? If you take similar mice, do the same thing to them, so treat them with high-dose antibiotics, sterilize their gut, get human tumors growing in them, and you do what's called a fecal transplant. So you take the feces of a mouse that's previously responded to therapy, you feed it to the mouse, then you give them checkpoint therapy, it works. So there's been a lot of research focusing on the microbiome. And we know that some bacteria seem to predict response. The bifidobacterium is associated with an improved anti-tumor response in mice. It's shown to enhance dendritic cell activation and improve tumor-specific CD8 T cell responses. Bacteroides fragilis and Burkholderia cepacia are associated with improved anti-CTLA therapy in mice. As I said, germ-free or antibody-treated mice did not respond to CTLA-4 therapy. Orally supplied B. fragilis and B. cepacia restored Th1 responses in tumor-draining lymph nodes. But unfortunately, the use of probiotics to date has not been proven beneficial. When I was presenting in Montreal last November, I was asked that question about whether or not I tell my patients to take probiotics, and I said no. And I said, in my anecdotal experience, those patients seem to take probiotics, just seem to have more toxicities, and they don't seem to do any better. And Dr. Miller from Montreal said he's got the same anecdotal experience. So we're not there yet. And I think at our meeting, we had a talk from a professor from the University of Pittsburgh. And he was, a lot of people want to go into phase 3 randomized trials. And he said, we're not there yet. He said, we don't know enough about the microbiome. It may be harmful if we try to manipulate it without better understanding it. So we're not at the point where we really can do these randomized phase 3 studies to prove that supplementing the microbiome is good. Now, feeding it may be better. So this is called prebiotics. So if you take care of your microbiome and you feed it well, it's more likely to give you a better immune response. So if you stay away from the McDonald's and the milkshakes and chips and have like lentils and beans and vegetables, blueberries, things like that, that will certainly help your microbiome keep it healthier. So these were 3 papers that were published, all from different parts of the world. They all show that certain types of bacteria predicted response to immunotherapy, but they're all different bacteria. So I think it just goes that 99% of what we see in the microbiome, we don't know where it's coming from, or we don't know what the DNA is. And so I think we need to know a lot more about it before we enter onto phase 3 trials. So in conclusion, I think the combination immunotherapy at this meeting, we clearly see that the whole thinking behind therapy in first-line metastatic melanoma patients has almost now all conformed to the use of immunotherapy upfront. Novel agents and combinations such as regatinib or relatinib are already in phase 3 trials. Over 1,000 immuno-oncology drugs are in clinical development, involving probably over 500,000 patients. The tumor microenvironment is a prime target, but really we don't know what we aim for. Some small phase 2 studies and phase 3 studies have failed to show survival benefit. The gut microbiota, I'm sure, is going to be very important in the future. Treatment of melanoma has hit a plateau. So really from 2010 to 2015, we had what people called a revolution of melanoma treatment. From 2015 to 2023, we've plateaued. We've made very minimal advances since then. Possibly relatinib plus nivolumab or other LAG-3 inhibitors plus PD-1 inhibitors will give us that option of durable survival, but with less toxicity. But we still haven't hit any major home runs since the 067 study. So hopefully within the next, I'm quite optimistic that by 2025, we'll start to see more home runs and we'll go beyond that 52% long-term survival and start getting even better than that. So with that, if there's any questions, I'm happy to take any questions from the audience or if we have time.
We've got time and quite a few questions actually, Dr. Smylie, but I'm going to start with actually the first one that came in about the mRNA vaccine, because there seems to be a lot of chatter around that in combination with an already existing immuno-oncology. Can you talk a little to that? Or
yeah, so that was briefly mentioned at the meeting, and I think it's early yet, but that's a BioNTech. So the same company that developed the Pfizer vaccine for COVID. So I think the mRNA vaccines are very interesting. They've been around for about 10 years, but we're just getting into the oncologic development of the vaccines. The early work looks very promising. And of course, there was that press release. The results have not been released yet. They're going to be presented, I think at the AACR is when they're going to be presented. So we haven't seen the results. We just know that they're better than PD-1 alone. But it's early yet, so it's promising. But I'm always a little bit skeptical about vaccines because, we've had vaccines for over 40 years, and there's only one vaccine trial that I know that was positive in prostate cancer, and that study design was heavily criticized. And nobody's using that vaccine in prostate cancer. Melanoma's had the most vaccine work of any cancer. And the big three randomized trials were all negative. And actually, in some of the trials, there was a trend towards patients doing worse if they got vaccine as opposed to placebo. So I'm hopeful that the mRNA vaccine will be, with PD-1, will be good. But I think this is not a new concept. I think a phase 2 study by Schwartz and Truber that looked at GP100 vaccine plus interleukin-2 looked better than interleukin-2 alone. So the very first positive trial of ipilimumab in melanoma was the MDX-020. And that looked at GP100 vaccine plus ipilimumab versus ipilimumab alone versus GP100 vaccine. And we thought that the patients who got the vaccine plus the ipi would be the best arm. So patients are randomized 3 to 1 to 1. And that arm was no better than ipilimumab alone. And as a matter of fact, if you look at the response rates, their survival, not statistically significant, but a little bit worse than ipilimumab alone. And there was more toxicity for the ipilimumab alone versus the GP100 vaccine plus the ipilimumab. So I'm hopeful, but I'm just, I've seen so many negative vaccine trials before with some early hype. So I'll hold my breath on that one.
Okay, another question just came in is, what about the TIL therapy or Rigver?
Yeah, so I didn't talk about the TIL therapy, but I think that's exciting. I think that TILs, Marcus Butler is doing a lot of TIL cell therapy. There are definitely some patients who respond. I think Lifileucel is a vaccine or the TIL therapy that was presented at ASCO 2 years ago. It was I didn't talk about that because we didn't really discuss it at this meeting, but they looked at a very heavily treated population. So 100% of the patients that received PD-1 therapy, 80% had received ipilimumab. And yet they still had a very impressive, I think it was a 26% response rate to TIL therapy. This is a commercialized apparatus. So usually TIL therapy is very expensive and time consuming to prepare because you have to biopsy a tumor, then you have to grow the T cells in it, prepare the TIL cells and infuse them back into a patient. Now with this lifileucel, patients also, they got the TIL cells, but they also got high-dose interleukin-2. So they don't talk about the high-dose interleukin-2 much, but that's, as you know, Kyle, that's a pretty toxic therapy. And so in somebody who's had a lot of treatment, to go through the interleukin-2 is pretty tough. But again, the results look quite promising. And I think it's the way of the future, especially the genetically engineered T cells.
Okay, next question is ctDNA testing. Will that eventually help us understand those resistant patients? Is there a way, we can in the future understand why for some these treatments work well and for others they just don't work at all?
Yeah, so it's hopeful. So it's not been validated in prospective trials, but we know that in lots of tumor sites that if you have circulating tumor DNA, that's often a bad prognostic sign. If you look at patients who take treatment and you cannot detect the ctDNA, they do better than patients who still have evidence of circulating tumor DNA. It may predict early responses. I think I would love to have it, but we're not going to get it until there's some validation that it actually can help with treatment decisions or improve outcomes in melanoma patients. But I think right now it's experimental, but it's promising.
Perfect. I think the next 3 or 4 questions is really about re-challenge. So we had a patient, and I'll just read the question. If a patient received a checkpoint inhibitor for adjuvant in stage 3 melanoma and progresses 3, 4, 5 years later, can they get a checkpoint inhibitor again, or is this considered resistant to that treatment?
Good question. And I think that this is one of our arguments. I think the evidence now, we just recently had a randomized study that was showing that dual blockade was better in patients who were progressed on single agent immune therapy. So as it stands now, that if you, and this is one of the reasons why some people don't want to use the PD-1 inhibitors in the adjuvant setting. if you have stage 3 melanoma, you're resected, and you start off on PD-1 therapy and you recur while on PD-1 therapy, or within 6 months of completing your PD-1 therapy, they will not fund rechallenge with PD-1. So as it is now, you can get ipilimumab by itself, but there's a retrospective series, there's a prospective small study by Olson, and recently another study that was talked about showing that clear superiority of dual immune blockade versus PD-1 therapy alone. Canada, we don't have access to it. Australia, Alex Menzies was saying that that combination therapy after progression on PD-1 therapy has now been approved in Australia, but Canada seems to be lagging behind. We don't have it yet, but Kathy, this is your next job, right?
Yeah, on it. Because that's actually, honestly, Mike, the first 5 questions are really about that, right? In the event they're clear for 3 or 4 years, or if they've had, if a patient doesn't respond to Nivo, how likely are they to respond to Ipi-Nivo? You know, and again, what other options are there for the BRAF negative melanomas?
It's about a 33% response rate in patients that progress. So it's a pretty good response rate in patients who have progressive disease on PD-1 therapy. But if you go over a year, then the response rates are going to be even better. So,
okay, how about melanoma patients with a CDKN2A genetic mutation with a high risk of new primaries? How do they recommend using the available evidence to guide their treatment decisions?
no, I haven't seen any evidence that drives treatment decisions. So right now we would treat them the same. But obviously those patients have to have a good dermatologist and undergo regular skin surveillance. Okay. And I think that anybody who's got a genetic syndrome like the dysplastic nevus syndrome or CDKN2A mutations, that those patients need to be followed at a specialized skin clinic. It's funny, you look back at your time, and I remember seeing a patient who came from up in northern BC, and she looked like she'd been attacked by a woodpecker. There was all these little punch holes on her and stuff. And I asked her, so she had dysplastic nevus syndrome. So I said, how are you deciding which nevi to take off? Because they all look abnormal. And she said, well, I don't know. It's kind of, I see my doctor and he doesn't like this one. I don't like that one. So it's kind of a mutual decision. There's no evidence that routinely taking out some of these nevi without clearly showing a change in them has any benefit on prognosis. And in fact, about 50% of all the melanomas will come from so-called normal appearing skin. And so I think what you really need is you need mole mapping, you need regular photography, and you need 6-month follow-up by a dermatologist.
Okay, next. Are melanomas in your legs harder to treat and less resistant to immunotherapy?
No, it's the melanomas in the leg are not. It's the truncal melanomas. The head and neck are the worst, and then the truncal melanomas after that. But the limb melanomas have always been shown to have a better prognosis. I think it's maybe because they have more of a, on the trunk, they have more of a ambiguous lymphatic drainage. And then, whereas the ones on the leg, we know where they drain to. So it's easier to identify the lymph nodes. So with the head and neck melanomas, they still do a little bit worse, but they tend to be melanomas that are associated with chronic sun exposure. So there's a good paper that was published by Leslie Fetcher about 8 or 10 years ago. And it was work from Boris Bastian. And at supper one night, we were talking about getting Boris Bastian back to the meeting. And they said that they would love to hear his update about the molecular classification of melanoma, because he basically broke melanomas into 4 main subgroups. There's melanoma without chronic sun exposure. So that's the majority of melanomas that we see. So it's usually areas of the skin that are intermittently exposed to the sun. And it's usually a younger population, more likely to have a BRAF mutation. And then there's the malignant melanoma with chronic sun damage. So it tends to be an older population. Usually head and neck melanomas are back of the hands, where you get the most sun exposure. And then there's the acral-lentiginous melanoma, which has no association with the sun. And there's some mucosal melanomas, which obviously have no association with the sun. And so they all have their own molecular profile. And so I think that, but as far as the limb melanomas, they seem to do a little bit better than the truncal and the head and neck.
Okay, what about RIGVIR, virology?
Sorry, which one?
Rigvir, Rigvir.
Yeah, I'm sorry, I don't know about that one, so
Okay.
I've heard about it, but I'm not updated on that one, so I can't answer that.
Okay. How about, is Avastin a good treatment for brain metastases, edema, and hematoma cure?
Yeah, not a treatment for brain metastases, but to control the toxicity. So the big thing when you get stereotactic radiation, it's you can get what's called radiation necrosis. And this is the bane of all melanoma treaters. Like you get the MRI, and I like it much better now because our stereotactic, like our Gamma Knife clinic, will book the MRIs and they'll do the follow-up every 3 months. Because when I have to book them, I look at it and the radiologist talks about progression. There's more edema. I think, well, is it progressing? Is it really progressing, or is it just radiation necrosis? You send it back to Gamma Knife. They review it and they say, well, we're not really sure, but just do another MRI in 3 months and see if it changes. And it's so difficult to deal with that. And sometimes this radiation necrosis becomes symptomatic. So in that instance, it's the Avastin is a very good treatment to control the edema and the radiation necrosis. So that's the one instance where Avastin is helpful.
Okay, another question about the herpes trials done for melanoma. Have we seen any of those?
Yeah, so that was the TVEC. So they basically used a herpes simplex virus that was genetically modified so that it could not replicate in vivo, and they put in GM-CSF, and I can't remember the antigen, but it's basically an oncolytic virus. And so this was dating back way back when they had John Bell, who was an oncolytic virologist from Ottawa. We talked about oncolytic virus, and he was working with a herpes virus that affects cattle, and they get it on their lips, and so he always said that cancer cells have achieved immortality, but he always said that they've achieved their immortality at the expense of the immune system, so they can't fight infections off as well as normal cells. And so I think these oncolytic viruses can be good vectors. So we know that if you take a virus and you insert DNA into it to make it more immunogenic, that it can infect the tumor cells and hopefully cause more of an immune response. But the TVEC in the phase 2 study showed improvement in survival for when you gave local therapy, but the randomized trial unfortunately came out negative. So I don't know what's going to happen to the TVEC, but I doubt it will be approved in Canada. It's good for local therapy, but then there's no evidence that works better than interleukin-2 injections or rose bengal or anything that causes an inflammatory response. So I don't think it will get funded in Canada because it will be expensive. There's no evidence it's better than what we have now.
Is that something that's still being done, the IL-2 injections, or?
Yeah, so so there's a lot of talk about it. So Claire Temple Oberly does it. Francis Wright does it from Toronto. Tom Salopek does it in Edmonton. So a lot of people, especially for the entranced metastases, the subcutaneous local injections of IL-2 are very effective.
Okay, well, I think that's it. I do have a comment that they're pleased to see the gut microbiome becoming a focus, as it was not even accepted as a valid question in 2015. So actually, thank you for presenting on that. I always find that myself extremely interesting. Dr. Smylie, look where we are today compared to your talk about, this was the 17th Canadian Melanoma Conference in Banff. And you and I had a little giggle this year that the very first one, I think there was maybe 20 people in attendance, and it was mostly faculty of the meeting and a couple pharmaceutical companies.
Right.
And our agenda was very short and sweet compared to where we were last weekend. We had 2.5 full days of new and innovative medicines and studies. So thank you so much for hanging in there with us, and we hope we have you for another 17 years at least. And I agree, we saw the tsunami of innovative medicines coming, and I feel like we're in a lull. So I'm hoping moving into the next couple of years, we're going to see lots more come into our space. So again, thank you so much, Dr. Smylie. I'm going to pass it back over to you, Jasmine, and thank you everybody for attending.
Yes, thank you very much, Dr. Smylie, for sharing your insight with us. We appreciate your time today, and in preparation for this session, we know how important this information is to Canadian patients, caregivers, and of course, physicians. And to all our attendees, thank you for attending today's webinar. Again, our sessions will be being recorded and will be available on our Save Your Skin website as well as on our YouTube channel. We will also send a link of the recording to all those that have registered here today. Je voudrais m'excuser auprès de nos auditeurs français pour les problèmes que nous avons rencontrés aujourd'hui. Nous vous soumettrons l'enregistrement à une date future via courriel. If you have any additional questions or would like to unpack further the information we learned tonight, we would like to invite you to join us tomorrow for our monthly patient fireside chat. This is a monthly Zoom call open to all patients and caregivers. Kathy Barnard will host this month's call as we digest and discuss in a more casual setting what we have learned at the Canadian Melanoma Conference. The goal of these monthly calls is to create a safe space to discuss your experiences, meet others who are going through something similar, and ask questions. To register, visit our website, and you can find our monthly fireside chat on our homepage under the events section. Thank you so much for watching. This ends our webinar.